Julie, the Cancer Dietitian. Thanks to a grant from the Colon Cancer Coalition, we're doing a 6-part series on colon cancer. This is episode 3, and we're discussing genetic risk, high-risk medical monitoring for colon cancer, and we'll hear from a patient who's been diagnosed with Lynch Syndrome. Let's jump right in. Okay, I am here with Thuy Vu. Thuy is a genetic counselor at Wake Forest Baptist Comprehensive Cancer Center, and she got her master's degree in genetic counseling from the University of Arizona, and she's been practicing as a genetic counselor for 16 years.
Hi, Julie. Thanks for having me on.
Sure. Thanks for being here. So she's going to share with us some of the things that we need to know about genetic risk for colon cancer, testing, and everything about that. So, Thuy, what should a patient consider regarding genetic testing? Like, when should somebody choose to ask for a referral?
So as far as like things to ask your providers about and think about your family history. So generally we recommend, colonoscopy for every person around age 50. But if you have family members who were diagnosed with colon cancer at a relatively young age, like before 60, that's a conversation you should have with your provider. Generally, we recommend screening 5 to 10 years earlier than that. And genetic testing should be considered when you have multiple relatives also with colon cancer, or you just have a relative diagnosed with colon cancer under 50.
Okay. So if someone in your family had colon cancer before the age of 50, then you should tell your doctor and ask for a referral?
Yeah. So a young onset case of colon cancer, it's several decades younger than when we anticipate colon cancer happening. And we recognize that that can be more enriched for having a genetic explanation for why that colon cancer occurred young.
So cousins, like if my cousin was diagnosed in their 30s, then should I get screened, or how close do you look at?
Yeah, generally we consider first or second degree relatives. So that would be like your mom, your parents, your grandparents, aunts, and uncles.
Okay, so first degree is like
first
mom,
degree is
brother,
parents, and siblings.
Okay.
And second degree would be your grandparents, your aunts and uncles.
Okay.
So if it's your cousin, that's a third degree relative.
Okay.
And so the idea is that if you have a cousin who was diagnosed with colon cancer at 40, but your mom and your cousin's mom are both fine, alive and well in their 60s, and they've not had any problems, that's pretty distant to you, right?
Okay.
And so it's helpful to let your doctor be aware of that family history, and kind of look at the big picture of your family history. So we generally, ask about your first and second degree relatives, so relatives that are closer in relation to you. And if you have someone diagnosed with colon cancer under 50, then we would consider genetics evaluation, or you have 3 or more family members with colon cancer on the same side of the family.
Okay.
So this would be like if you had 2 cousins and your aunt who had colon cancer, regardless of age.
Okay.
Because statistically, the average person has a 5% risk of getting colon cancer. That's 1 in 20 people. Mm-hmm. So if you play the odds and you have 3 people and your family doesn't even have 20 people,
right,
that's pretty unusual odds there to have that many colon cancer in closely related people. And so then we want to evaluate if there might be some genetic risk explaining this history.
Okay. So that's kind of the key indicator is anybody in your family who's been diagnosed with colon cancer, either at a young age or multiple people in your family.
Right.
And that would then refer you. Okay. So let's say someone is at risk and they're referred, then what's the next step on that?
Sure. Well, the other consideration is if you yourself have had more than 20 colon polyps in your lifetime.
Oh.
So we recognize that smoking is a risk factor for precancerous colon polyps. And we, the reason why we start colonoscopies is that we find polyps and we remove them, right? So we can really reduce your risk of colon cancer if you continue with regular colonoscopy screening. But if every time you come in, you're getting a handful, a dozen polyps each time, that's a lot. That's more than what we would typically anticipate. Or if like your sibling or your parent had a colon polyp that was considered one of the precancerous kinds and they were not even 50 yet when they had this found, that's sort of like, that's unusual, and we would be concerned if there might be a genetic explanation, an inherited genetic risk for that history.
So yeah, this starts to make like holiday gatherings rather interesting, I think. Because when we talked about colonoscopy in our first episode, the GI doctor was talking about if you have precancerous polyps in your family, for family members who've had colonoscopies. And I'm like, well, I don't know that I've ever asked my parents, like, what were the actual results of their colonoscopy.
Fun time Sunday dinner conversation here.
So, yeah, now I'm like, okay, I need to ask, like, my parents and my husband's parents what their colonoscopy results are, and now also ask them how many. What's their polyp count?
Not the funnest conversation, a little weird, but the idea is that like if there are just a lot of precancerous colon polyps, then that person needs to be screened more often, right? And so we want to assess each person for their own individual risk factors. But if all of like your siblings and your parents, they keep having colonoscopies with polyps found each time, that's really unusual.
Yeah.
And so we just want to make sure that if there is a genetic risk that puts you and your family members to have a higher lifetime chance of getting colon cancer, that instead of saying, well, you can have a follow-up colonoscopy in 5 years, for example, we may back it down and do it every 2 to 3 years, or even 1 to 2 years if you have Lynch syndrome or one of these other hereditary forms of colon cancer.
Right. And like as a reminder for people, having precancerous polyps removed is like true cancer prevention.
Absolutely. Right.
So yeah, that active monitoring can be a way that hopefully people can avoid having to face a diagnosis and go through treatment if at all possible. It's not a guarantee, but that would be a good factor. So then GI doctors, do they also refer for genetic counseling after a colonoscopy?
Anyone can refer patients. So oftentimes a gastroenterologist, if they note that you're young to have a precancerous polyp or you've had lots of these precancerous polyps, yes, they should have that conversation with you and recommend you have a genetics evaluation, or even just with your annual check-in with your primary care doctor, right? As they're reviewing your family history, and you make a note that, my mom had colon cancer and her sister had uterine cancer and I had a grandmother with breast cancer. And, these are all different types of cancers, but if the pattern is that there's just a lot of cancers in the family and people tend to be much younger than typical when they were diagnosed with these cancers, or it's a recurring pattern of the same types of cancers in the family, then we do get referrals from like GYN providers or primary care providers.
Okay.
And from their perspective, they want to assess if you have this inherited risk because they might implement mammograms on you earlier or colonoscopies earlier or more frequently, or do more than just your typical pap smear pelvic exams. They might start ovarian and uterine screening, which we don't recommend for the average risk woman.
Right. Okay. So that's interesting because I'm wondering, like, in a regular visit, do primary care doctors usually go over family history and then refer, or is it sometimes fall on the patient to bring it up with their doctor?
I think it's both, right? I do get a lot of referrals from primary care providers, and I always ask the patient, like, so who initiated this this appointment, right? Was it your concern or was it your provider's concern? And I really get a mixed 50-50 response that, oh yeah, I read something in the paper, or my family and I were talking and we were just worried and I asked my doctor about it and she thought it was a good idea that I see you.
Okay.
And then at other occasions it was like, I wasn't really worried about my family history, but my doctor was like, I'm concerned about the number of people with cancer in your family. Let's have you have a genetics evaluation because maybe I need to start your screening earlier than average risk.
Yeah. So, okay. I think that's really good for people to remember that they need to bring it up, or their doctor might bring it up, and it's important to hear what the doctor's saying. How urgent is it? Like once, say, the patient and their doctor kind of decide, yeah, probably need to get evaluated by genetic counselor. How urgent is it that the person be seen? Like,
quite variable.
Okay.
So typically it's not super urgent that you need to be seen tomorrow or even next week, right? I see patients who are newly diagnosed with colon cancer, and in those cases, the surgeon does request that I see the patient within the next week or two, because if they have a gene mutation that explains their colon cancer, they might have a higher risk of getting another colon cancer or other types of cancer. So before the surgeon performs their surgery, they may want to do additional imaging and lab work to screen for anything else.
Gotcha. So
just
that
for surgery planning.
Helps, right, with treatment planning. So it might be urgent for them.
Yeah.
But for somebody,
and then for someone with just a family history and they're just, concerned about it, usually those appointments are scheduled a few weeks out. Okay. And part of it is that it gives the patient a time window to call family members and get more details about the family history, right?
So they do that before they see you.
So most appointments, like at Wake Forest, when you're scheduled for a genetic counseling appointment, we mail you a questionnaire that helps you to organize your family history. So it asks about your own, cancer screening history, but then it also walks you through your parents, your siblings, your aunts, your uncles, your cousins, and we want to hear about everybody. Even if they've never had cancer, we want to know how old they currently are, how old they live to be. For anyone who's had cancer, we want to know age at diagnosis and, of course, the type. And the reason why we do this is that we often hear stories about our family history, but when I ask you for details, that gets a little fuzzy, right? Or if like your mom was sort of the data keeper for all of its history here, I want to give you time so that you can call your mom and sit down and organize this information. Because the more accurate information you can give me when you come in for your genetics evaluation, the more comprehensive my risk assessment can be for you and your family, right?
Right.
And so we can tailor your genetic testing based on what we see in your family so that it can be a comprehensive, full analysis of any possible syndromes that I might be worried about.
Gotcha. So they do all this paperwork.
They bring it in, and
come
then
in, see
when they
you.
meet with me, we draw out a 3 to 4 generation family history. So we ask about your grandparents' generation, your parents' generation, and then your generation. And we draw it out. And often by looking at it visually, we can kind of see that pattern. They kind of pop off the page a little bit more if there is something that's worrisome. And a lot of times there may not be a pattern. So even though your mom, your aunt, and your grandmother had these cancers, your mom had 10 siblings, right? And the other 8 of them had no cancer. So it just puts the cancers into the bigger perspective of your whole family history. And so I think that just visual drawing of your whole family tree is a nice way to kind of help patients see that maybe the cancer isn't as bad as I thought, or, oh man, like I should have paid attention to this a lot more.
Yeah. Okay. So they come in, they have all the data that you help map it. How long is that first appointment?
The first visit is usually 45 to 60 minutes.
Okay.
It's pretty long.
I'm like, well, that's pretty good for drawing this big old map.
There you go. And, we're here in the South, so some families have 10 siblings and other families have not as many, right? But I want to give, I consider the person in front of me not just my patient, I consider their family as my patient, right? Because I fully understand that some people are coming in and they're getting this information and they're going to share it with their siblings. And because they've called their family members to get details about the family history prior to coming in, a lot of patients are like, I got to call my aunt and follow up with this, or I got to call my cousin and ask about her genetic test results and put the pieces together.
Right.
And oftentimes, the person in front of me may not be the best person to initiate genetic testing because they've never had cancer. But their mom and their cousin did have colon cancer young. So maybe that person would be the better, more informative person to initiate genetic testing, right? And so we kind of discuss all the nuances of this. And obviously you can't make a person do genetic testing. But I think if you understand the implications of who starts it and when and the why of it, I think the family can better understand like the whole picture and how the results spill over to everyone in the family.
Yeah, I think that's interesting because so there are some people who come into you and they don't actually need to go further with testing, right?
Right.
You've looked at their family tree and you're like, yeah, probably don't need to go through with testing.
Right. So there's this misunderstanding that when you are referred for a genetic counseling appointment that you will have genetic testing. So that's not the case. So the genetic counseling, it's more of a family cancer risk assessment. So the first tool, right, is reviewing your family history, reviewing if you have any personal risk factors for cancer. And then from there, we'll discuss, number one, is the pattern concerning for some hereditary risk? And how could genetic testing be helpful for you and your family members? And who should start that genetic testing process? The other part of it is that whether or not you or your family members do genetic testing, we can still assess your own cancer risk based on your family history and your personal lifestyle risk factors and these other variables. And so at least the patient can take away to say, well, yeah, my mom had colon cancer at 45. And so maybe I need to start my colonoscopy at 35, much earlier than typical. And so you can be a better advocate and have this discussion with your provider to get your own health screening tailored.
Gotcha. So yeah, there's lots of reasons to come in and see you and not just to give you blood.
Yeah. And actually, the U.S. Surgeon General has recommended for a long time that Thanksgiving be considered Family History Day. For all the reasons you just said, right? So it's like when you're eating your pumpkin pie and you're just sharing desserts with each other, ask about your family history. And when you ask about family history at any time of the year, you want to make a note of when people were diagnosed with things, right? So I'm focused in cancer, so I want to know when your mom was diagnosed with her colon cancer or her breast cancer, because you could have someone who had cancer for 2 years or someone who had cancer 20 years ago. Right. So in my world, for genetic risk assessment, a colon cancer at 35 is way more unusual and more concerning for possible genetic risk than a colon cancer at 65. And so making a note of when people are diagnosed with cancers or even like heart disease, diabetes, any health condition that you're concerned about in your family, that helps your provider identify if there might be a pattern, and also when we need to start screening you at an appropriate time.
So let's say someone in your family has colon cancer. It would be most appropriate for them to get the testing, but let's say they don't want to.
Can't make everyone do anything.
You cannot make them do it. So in that case, would it be appropriate for the person who's in your office to then be tested?
Absolutely.
Okay.
So, I think just the way our society is now, right? Like we're a much more mobile society. So family members all don't live within a 10-mile radius of each other anymore. And you may have relatives in Michigan, California, all over the country. And you may not be as close to these people anymore, right? So just because you are friends on Facebook doesn't mean you know all the intimate details of their medical histories either, right? And so I acknowledge all of these barriers and limitations, right, and constraints that we have. And so when a family history is very concerning and the patient doesn't think that their mom or their cousin, that they could talk to them about this or that they would be willing to do testing, we can facilitate genetic testing for the person in front of us. We just acknowledge that there might be having a negative result in someone who's never had cancer may not completely rule out that the family doesn't have a genetic susceptibility.
Right. It doesn't rule it out for everybody. It just rules it out for that individual.
So for that person, we can say, well, great. You had a panel of 20 genes related to hereditary colon cancers and you have no mutation found. So that's very reassuring for you to have that information. But because your mom had colon cancer at 45, I still want you to have a colonoscopy at 35.
Right.
So we still use your family history as a big tool to modify and tailor your own cancer screening.
So let's say that somebody had genetic testing, like they were diagnosed with colon cancer. They had genetic testing maybe 5 years ago or something. Maybe it was kind of newer. Is there a reason that they should get tested again?
Yeah, that's a really good point to bring up. So, we tried to improve and expand the genetic testing. So genetic testing for hereditary cancer has been around since mid-1990s, actually. And initially, it was genetic testing for Lynch Syndrome and the familial polyposis conditions. But it was like, if we were worried your family had one condition, it was one test, one charge. And genetic testing was really expensive. And if we thought your family might have a different genetic condition, it was another test, another charge. And so we had that sort of paradigm for genetic testing for a really long time. And it wasn't until about between 2013 to 2015 that we became more efficient with our genetic testing. So since then, we pretty much offer what's called panel testing, or sometimes we refer to as NGS testing. And so with panel testing, we can do one test, multiple genes, multiple syndromes, all in one assay. And so we can get
assay means
in one test, sorry, yeah. And so in one test, we can get all these genes, right, figured out if you might have a mutation in any one of these genes, and it's one charge. And so we're much more efficient about it. And so for families that we're really concerned they have a genetic risk because of multiple relatives with young onset of cancers, it's multiple generations of people with cancers, certain patterns of cancers that may be concerning. if they had genetic testing that was negative years ago, even as long as like as recent as 5 years ago, it's worth the conversation with your provider or reaching out with your genetics office to ask them, right, to review if your genetic test is something that we would upgrade and we would offer more of the more current panel tests.
And so let's say I came in and, I got genetic testing, and do you keep those samples and do you check them again later and then let me know if I tested for something, or is that
it's a one and done kind of deal?
Yeah.
Well, yeah. So typically genetic testing involves providing some form of DNA, right? So traditionally that's a blood draw, but many of the labs offer a saliva option as well. So it's the cells in your cheek that have your DNA, just the same cells that have your blood cells. And then we send it off to a lab. So genetic testing is not common, and so most of them are not done by your local hospital. They're sent out to external labs, and the labs will be the one that bills your insurance and performs the genetic test. And then the results are mailed back to the genetic counselor or your ordering physician. And then from those results, when you get a genetic test report, there's 3 possible test results. It could be positive. We actually find an actionable mutation. So that's something that raises cancer risk for you and your family members. And so we would discuss, what that means and how your cancer screening would change. It could be a negative result. We looked everywhere and all the genes were totally normal. And then the third result is considered an inconclusive one. So it's called a variant of uncertain significance. Is exactly what it sounds like. Most of these uncertain results, they end up being reclassified as benign results. So if you have one of these uncertain results, I treat them as negative results and I reassure my patients. These uncertain results do get reclassified down the road, and it could take 2 years or even 10 years or more. But the lab doesn't need your DNA after that. They keep that particular result on file, and they just update their database and their evidence on that particular result.
So if they somehow found that was a match for something later?
Right. So through further research efforts, lab collaborations, they may figure out that this particular result now does raise risk for colon cancer, right? They reach out to the provider who ordered your genetic test, and they send them an amended report.
Okay.
And that's based on your original blood sample. So if you have an inherited genetic risk, that's a mutation that you were born with. You've had it your whole entire life, right? So when we recommend you have more genetic testing, it's because we're using new technology and looking for new genes.
Okay.
But it's not because your genes have mutated or changed, right?
Right.
You've always
it's
had
not
these
your genes. It's the same genes that maybe match for something we know about now that we didn't
It's
before.
how we would interpret, right?
Yeah.
And know what we would know about that particular gene result. That could change over time.
All right. So do they mail the patient a letter too, or do they just go straight to the...
Typically, I would call my patients and discuss results by phone, and then I mail them a whole packet with their genetic test results, with their summary note. And it's a thorough risk assessment of their own personal and family cancer history. So I have patients that tell me they make copies of it and they distribute it to their siblings and their kids because it communicates exactly what genetic testing they had and what it means for their children and their family members, right? So you should get a summary note to kind of put all the pieces together, because the risk assessment is not just for you, right?
Yes.
It affects everyone from your
family.
gene pool, right?
Yeah.
So your parents and your siblings and, of course, your kids.
All right. So, there's some popular kind of pay for your own genetic assessment like 23andMe. So please explain why that doesn't count as genetic testing.
So when you come to me and I coordinate your genetic testing, that level of genetic testing means that it's like if we're worried you might have Lynch syndrome, for example. That is the most common form of hereditary colon cancer. And there are 5 genes that can cause Lynch syndrome. So if I'm worried you might have Lynch syndrome, your DNA test would include full analysis from beginning to end of the entire 5 genes that can cause Lynch syndrome. If you were to send off for Ancestry.com or 23andMe or some of these other companies, and they also can test for these health conditions, what they're doing is that they're looking at very specific markers within a few genes. So it's not full DNA analysis at all, full gene analysis. It's just very targeted testing. So it'd be you threw a dart, you threw several darts at the wall, and whatever it landed on is that marker of DNA that I will analyze to see if you have. And so that level of genetic testing, if we're really worried you might have Lynch syndrome or something else, it's not sufficient.
Is it even useful?
Like with 23andMe, you can learn if you have wet or dry earwax. I mean...
Oh, that sounds practical.
So yeah, lots of people want to know that information. I
don't.
So with 23andMe, they also claim we analyze for the BRCA1 and BRCA2 genes. So I know this podcast is on colon cancer, right? But the BRCA1 and BRCA2 genes account for the majority of hereditary breast cancer. And so what 23andMe tests looks for are 3 very specific mutations within BRCA1 and BRCA2. That's it.
Not all of them.
Not all of them. When I send off for BRCA1 and 2 analysis, it's full analysis of BRCA1 gene, full analysis of BRCA2 gene, and there are hundreds of unique mutations within each of those genes. And so, yes, you can say I had BRCA testing and it was negative, but the likelihood that you would have one of these 3 mutations is very low. And so I would consider it totally incomplete analysis of it.
And the danger would be somebody would think that they had it done when they really didn't.
Absolutely. It's not a full assessment of whether you have that genetic risk or not.
Gotcha.
Right.
So we're going to hear from somebody who has been diagnosed with Lynch syndrome. Can you give us kind of a basic understanding of what that is?
Sure. Like I said earlier, right, it's the most common form of hereditary colon cancer. The main cancers we associate with Lynch syndrome is young onset of colon cancer, and these people may also develop multiple different new colon cancers over their lifetime. So for these patients, they need to have a colonoscopy every 1 to 2 years lifelong, because we really want to stay ahead of those polyps and remove them and not give them any chance to turn into malignancy. And we actually start colonoscopies really young in these folks, because the average onset of colon cancer and Lynch syndrome is in your mid-30s, early 40s. So we recommend they have colonoscopy starting age 20. So it makes a huge difference, right, if you know you have Lynch syndrome or not. And that's where the genetic testing can be such a powerful tool, right, for you and your physician to know that.
Yeah.
We also associate Lynch syndrome with gynecologic cancers. So there's a higher risk of uterine and ovarian cancer. And so for women starting age 30, we recommend they have additional GYN screening beyond your routine pap smear and pelvic exams. So we do a transvaginal biopsy, CA-125 blood test, and even endometrial biopsies, because we're making sure that there's no precancerous changes in the ovaries or the uterus. And then many women may even choose to have a hysterectomy to manage her uterine cancer risk, if she is done having kids or she's, it's after menopause. Right? Okay. So, knowing if someone has Lynch syndrome, it can impact your screening at a much earlier age, and we would do things very differently, more frequent for these families.
Wow. Okay.
It's a lot to consider.
This is a lot of really great information. Thank you so much for sharing your expertise.
Thanks for having me on here.
Yeah, I look forward to having you on again another time, and we can share other tips and things. So
that's great.
Thank you so much. Next, I am here with Jill Hyson, who actually has been diagnosed with Lynch syndrome. It's been about a year. And so thank you, Jill, for coming and sharing with us.
Oh, you're welcome. You're welcome.
So tell us about how you found out of this genetic mutation that you've been diagnosed with.
So it all started with my mother's sister. She was diagnosed with breast cancer, actually, about 6 years ago, and had just BRCA testing for the BRCA1 and BRCA2. And she met with a new GYN physician, and they got to talking a little bit more about our family history and said, I see something here. Let's refer you for an extended panel. So she had the extended panel, and she, come to find out, had Lynch syndrome, and hers was specific for MSH6 in the Lynch family. So then she calls my mom, and my mom went and had her testing done, and mom's positive. So then mom was like, okay, we need to have you, and I have a sister, you need to get tested as well. And I'm very fortunate to have access to genetic counselors. And so we went and had our testing done. My sister had blood drawn, and I had something to eat, I think, or was chewing gum. I can't remember. But anyways, I had the saliva done. And it took about 2 weeks for the test to come back. My sister's negative, which is okay because she has 3 girls. And I'm positive. I only have 1 son, which is okay. So then that kind of snowballed into, okay, where do we go from here? So I met with my genetic counselor, and we went over sort of what the next steps were. I was in the process of changing my primary care physician, so I wanted to wait until I kind of met with her, and so I could kind of walk in and say, this is what I need based off of what I was sent by my genetic counselor. So I met with my PCP, and she walked in, she said, oh man, this sucks. I was like, what? And she was like, you're Lynch. And I was like, oh yeah. I was like, let's talk about what we need to do. I come from a medical background, so just to let you know that, so I was kind of on top of stuff. So first things first is I had already had my mammogram because I do need to have my mammograms anyways, just because of breast cancer risk. And then she said, well, let's get you in with the skin dermatology, and we'll get your skin checked. So that's kind of the first thing that I did, because it was the first opening that was available was the dermatologist. So we did that. And then it was sort of, what are we going to do about my colonoscopies, and sort of now we need to look at sort of GYN cancers, because my mom had an endometrial in situ, which means that she didn't have invasive endometrial cancer, but she had sort of the beginnings of it that happened right after she had some postmenopausal bleeding, and they went in and she had a complete hysterectomy, and that's where they found it for her.
Wow.
And this was before she even had the Lynch syndrome.
Her testing. So that was kind of, I guess, fortuitous that she'd had the hysterectomy and they caught it before.
Right. And then she had testing 20 years later.
Right.
So she,
Okay.
So she was diagnosed with that at like 54, 55, and then had testing when she was 71, I guess. Yeah, 71. I'm trying to remember how old she was. So she, with that history, we kind of jumped on the bandwagon of what am I going to do GYN-wise, because I'm 44, whether I was going to, have a hysterectomy. Was I going to keep my ovaries? Was I not going to keep my ovaries? So I met with a surgical GYN doctor, and I advise people if they have any kind of sort of genetic, Lynch or BRCA or anything like that, any kind of surgery that they're thinking about having, is go with somebody that has surgical oncology in their name.
Okay.
Don't just go to a regular surgeon. You need to have somebody that has oncology in their name, so that way when they go in, they know what they're looking for.
Right. So because the risk is high, you want somebody who knows what cancer looks like when they're in there doing the surgery. Gotcha.
Right. So I met with my GYN oncologist and kind of went back and forth, because I was really, really not thrilled about having my ovaries taken out, because I did not want to have to go through menopause at such a young age. And then we talked about the risk of ovarian cancer. I mean, it is low, but he was really nice. He went through the NCCN guidelines. He pulled articles for me. We kind of went back and forth with that. He presented me with more information. So that kind of helped me with my informed decision. And so on August 6th, I had a total hysterectomy and had my ovaries taken out. And it's been since August 6th. And so right after that is we decided to go on just a low dose of estrogen, because I was worried about the breast cancer risk of, you hear about all that way back when. And it was such a low dose that it wasn't going to have any effect on that breast cancer risk. But yeah, I decided to have a total hysterectomy with my ovaries taken out. And I'm glad I did. All of my organs were okay, but my pelvic cavity actually had some atypical cells in there.
Which is possibly could be like pre-cancer.
Exactly.
Okay.
So we had all that taken out, and then I immediately had emailed or messaged my GI doctor, because I had already been established with a GI doctor at the medical center for other problems. I said, hey, I have Lynch now. I just, had my hysterectomy. We saw some atypical cells. Can we go ahead and do my colonoscopy?
I want my colon checked.
Yes, I want my colon checked. And he was like, absolutely. So he was like, we're going to do a colon. We're going to do an EGD. We're going to, look at your pancreas. So he did the whole kit and caboodle. And I just had that done in October.
Okay. So EGD is
where they go from the top.
Gastric.
They're looking at, they're looking
through your mouth to your stomach.
Yeah,
okay,
so they're
and
looking,
duodenum, I guess.
Yeah, so
which is just below your stomach.
Yeah, so they're looking kind of from above.
They're coming from the top, looking down, and then the colonoscopy comes from the bottom, looking up. And typical risk people would just have a colonoscopy.
Correct.
But you had like all of the organs checked out.
Yes.
Okay. And how did that go?
Oh, it was great. Everything was negative.
Oh, and I bet it was a lot of fun too.
Yes. And it was my second one, so I was kind of already used to what happens. The procedure itself is not that bad because you're asleep. If anybody is going to have a colonoscopy, I advise you to have it first thing in the morning. That way you're finished your prep and you go straight in and have it done, and then you're fine.
Then you can have a nice lunch.
Yes. But it's not so bad. It's not too bad.
So then at this point, you've kind of done like a lot of the initial like, oh, let's check and make sure there's nothing. Let's remove organs that, maybe are at high risk that you don't want to have around anymore.
Right.
So are you now to a point of like active monitoring?
Yes. So we'll have, I'll have another colonoscopy in 2 years.
Okay.
And then obviously I'll have my mammogram on a yearly basis because I do have some breast cancer in my family, and now I have this Lynch that puts me at risk for colon cancer, so I'm on top of all of my screenings now.
Gotcha.
Not just my colon screening, but also my breast screening too.
Right. So it's kind of a shocker, I guess, to have this put on you, and we're honestly all at risk for cancer, but to kind of have your risk put right in front of you and seeing family members diagnosed, like, how do you handle that in a way that, I guess, doesn't cover you with anxiety or worry?
It's hard. When I first learned that I had Lynch syndrome, it kind of didn't really hit me, really. I was like, all right, I'm just going to go ahead. I'm going to do my screenings. I'm going to, do what I'm supposed to do based off of the NCCN guidelines and what my genetic counselor told me I needed to do, and, in conversation with other providers. And then when I, had my hysterectomy and had that sort of scare, I was like, ooh, I need to kind of change my habits a little bit. So I, got on your website, actually. I got on your Cancer Services website.
Oh, great.
Yes. As far as nutrition, and kind of added more sort of fruits and vegetables into my diet, cut back on my alcohol intake. Not that I would drink a whole lot anyways, but just, just being more proactive in my own health. And then, just continue with my monitoring. I don't let it get to me. I live my life. That's what I do.
Yeah, I guess I compare it a little bit to when people get a diagnosis and they go through active treatment and then their treatments are over and then they're like, whoa, what's happened, and now how do I kind of go about life? So I'm sure it's not easy, but you figured out, okay, I'm going to take control over the things that I can.
Right. Yeah.
And then somehow, focus away from the things that you just don't have control over.
Right. Just continue doing my screenings and not let it affect me as much as I can.
So have other family members also had to do more active monitoring?
Yes. So my aunt and it's funny, the other day my mom had gone, she had to have some colon surgery for some other issues, and ended up everything was okay with her as well. So then she got back in with her GI doctor because said, Mom, you need to schedule your colonoscopy, you need to get back in with him since you've had your surgery, because didn't he say you need to follow up with a colonoscopy? And she was
this is good family support, gentle reminders.
Yes. So she did that, and she, had texted me and said, I got my colonoscopy scheduled, tag, you're it. And I'm like, I'm done for the year. So it's kind of like, we just kind of keep on top of each other. My aunt's the same way. Now, unfortunately, the rest of my family lives in Pennsylvania, so we do more through text and phone. But my aunt's daughter has been tested, and she was positive. And so she's had her colonoscopy. She had her hysterectomy. She kept her ovaries because she is younger than me. So that was a conversation that obviously she had with her provider, because she's so much younger than me, that she decided to keep her ovaries. And at some point she'll go back and have her ovaries taken out. Yeah. And my aunt had a hysterectomy, but had her ovaries intact. So when she found out she had Lynch, she went back in and had her ovaries taken out too. But so
you do talk about it with your family now, for sure.
Yes, we're a pretty open family, so we do talk about it. Just making sure that everybody is on top of everything.
I suppose that also helps, like from a supportive standpoint, to know you're not like other people, your family's kind of in it together.
Right. We're not alone.
So yeah, which is
we can
nice.
kind of talk about it and, make sure that we're all staying on top of all of our screenings. Yeah.
Well, thanks so much for coming and sharing all of that with us.
Yeah.
And I hope that people listening will hear about genetic testing if they're needed, and to not be afraid of what they might find out, because it ought to be more empowering and give people more control than anything else.
Yes. Thank you.
Thanks for listening today to the Cancer Dietitian Podcast. I'd always love to hear your feedback and suggestions for future topics. Be sure to follow me on social media. I'm at Cancer Dietitian on Facebook, Twitter, Instagram, and YouTube. And of course, you can find me at cancerdietitian.com. Share this episode with your friends and encourage them to subscribe to the Cancer Dietitian Podcast. Thanks, and see you later.